she will be taking a gap year. A gap year, which, if you don't know what that is, can be found on the front page of the announcements for Science Seminar, where there are links that help you think about what you could do during your gap year to enrich your lives. But Kelly's not talking about her gap year today. She is talking about neuroprotection after a traumatic brain injury. So, Ms. Todt, please, the stage is yours. Thank you.
On January 28, 2012, my life was changed for what I thought was the worst, but for what I have discovered to be the better. It was on this very day that I was fortunate enough to receive a traumatic brain injury at a track meet of all places. For 3 months, it felt as if my brain was waging a war against itself. I was plagued with memory loss, confusion, little to no motivation, many of which the professors in this room, minus Dr. Ongs, can attest to. For instance, Dr. Bloomer once witnessed me crying in the middle of physics lab uncontrollably. Dr. Fitz and I once had a conversation in which she told me I was speaking out of one side of my mouth. And Dr. Gilmer, who was not here, witnessed my absence many times in physical chemistry because either I forgot we had class, I forgot to go, or I didn't feel like getting up out of bed and going to class. So it was also this very event that sparked my interest and deep passion for the topic of today's conversation, as Dr. Fitz said. So without further ado, I present neuroprotection post-traumatic brain injury, lead glutamate scavenging. So before I delve into why we want to scavenge or take glutamate out of the bloodstream following a traumatic brain injury, let's characterize glutamate some. Glutamate is the most abundant excitatory amino acid neurotransmitter in the central nervous system, accounting for 60% of total neurotransmitter activity. Glutamate is a non-essential amino acid, meaning that our bodies naturally synthesize or make it. Glutamate, the receptors that we will be acting on or talking about today are ionotropic, meaning ion poor, AMPA, and NMDA receptors. For responsibilities, glutamate is essential for regulating neuronal communication, as well as developing plasticity, which is the ability of our brains to change, creating new connections between neurons to compensate for lost or damaged ones. Excessive glutamate accumulation within the synaptic cleft, which is the area between neurons, leads to prolonged excitatory synaptic transmission of glutamate and excessive activation of glutamate receptors, such as AMPA and NMDA receptors. This excitatory activity leads to a process termed excitotoxicity, in which the neurons are literally excited to death. Excitotoxic mechanisms are generally seen in acute brain insults, such as a traumatic brain injury. Traumatic meaning that the injury is characterized by a forceful impact to the skull from an external object. For instance, getting the weighted end of a pole vault pole conveniently kicked into your head is an excellent example, in my opinion. The mechanism is as follows. Upon impact to the head, there is an inadequate blood supply, or ischemia. Inadequate blood supply correlates with an inadequate amount of oxygen. Inadequate oxygen correlates with the failure of ATP-reliant ion pumps, ion channels on our neuron here, meaning that the cell depolarization can now happen because ions are allowed to come into the cell. Cell depolarization means that we are making the membrane potential more positive. This depolarization allows, there's voltage-gated calcium channels on our neuron. When the potential reaches a certain voltage, these calcium channels open, calcium rushes into the cell. This calcium, along with various proteins inside the presynaptic neuron, cause the release of synaptic vesicles containing glutamate. Here. Once glutamate is released, it can now bind to its receptors, NMDA or AMPA receptors. Initially, glutamate binds to NMDA and nothing happens. This is because in NMDA there is a magnesium block. However, Glutamate, when it binds to AMPA, allows sodium to come into the cell. This sodium causes depolarization of our postsynaptic cell, which causes ionic repulsion of the magnesium block. So now when glutamate binds, calcium can come into the cell. It is excessive calcium influx, which is the key event in excitotoxicity. Calcium overload leads to the generation of harmful chemicals, such as free radical formation, reactive oxygen species. It also leads to the generation or the activation of certain calcium-dependent ions, such as proteases, phospholipases. These phospholipases break down the cell membrane, thus allowing harmful ions to flow into the cell. Calcium can also be distributed to the mitochondria, where it'll cause the mitochondria to swell, therefore being in a hypertonic state and no longer being able to produce energy. So the mitochondria breaks down, releasing apoptotic factors into the cell, leading to programmed cell death and thus the death of the neuron, excitotoxicity. Under normal circumstances, excess glutamate in the synaptic cleft can be taken up by an excitatory amino acid transporter located on astrocytes. Astrocytes, their job is to clean up, basically. Astrocytes will take glutamate and convert it to glutamine synthetase, which they'll then take glutamine and transport it back to our presynaptic neuron, where it'll be converted back to glutamate, packaged in the vesicles, and the cycle continues. However, when we have a traumatic brain injury, this mechanism of removal is exhausted. So our other option is blood glutamate scavenging. Blood glutamate scavenging means that we are decreasing blood glutamate levels. So we're creating a concentration gradient. So now we're going to have a ton of glutamate in our head where the impact has happened, and we're going to have low concentrations in our blood. So glutamate natural is going to want to go from an area of high to an area of low concentration. Once in the bloodstream, blood-resident enzymes, glutamate pyruvate transaminase and glutamate oxaloacetate transaminase, will convert glutamate to alpha-ketoglutarate. It's an active form. When it's bound to its respective co-substrates and blood glutamate scavengers, pyruvate and oxaloacetate. These blood glutamate scavengers alter the equilibrium and thus push the reaction to the right. Leads us to our hypothesis. Does the use of blood glutamate scavengers, pyruvate and oxaloacetate administered after an acute brain injury correlate with improved neurological outcome based upon the neurological severity score, which I'll be explaining in a moment. To address this question, we'll be looking at two studies by Dr. Alexander Zlotnick. Their first study assesses neurological improvement with pyruvate administration after a traumatic brain injury, and the second assesses it with oxaloacetate post-traumatic brain injury. Methods. Zlotnick used male Sprague Dawley rats weighing 200 to 300 grams. They were put under general anesthesia. The scalp was incised, the tail artery was catheterized for blood sampling, and the tail vein was catheterized for drug administration. Then, a traumatic brain injury was simulated by way of a closed head injury, which is what we will refer to it from now on. A silicone-coated free-falling rod delivered a cranial impact of 0.5 joules, 1 to 2 millimeters lateral to the midline. The rats were then sutured back up, and they were allowed to recover for 1 hour with access to water and food. After the 1 hour recovery period, they underwent the neurological severity score. A blinded observer was given a rat, and then was told to, and then based upon a point system, gave them values for motor functions and behavior. They were granted points based on the ability to exit a circle, to walk in a straight line, balance on a beam, reflexes, etc. A score of 25 correlates with a severe traumatic brain injury, and a score of 0 correlates with maximum neurological functioning. Our experimental design. 15 minutes after this 1-hour neurological assessment, rats were intravenously given solutions containing saline, pyruvate, oxaloacetate, glutamate, or glutamate plus the blood glutamate scavengers. So for the first experiment, Zlotnick et al. Wanted to study the neuroprotective properties of the blood glutamate scavengers, pyruvate and oxaloacetate. The methodology was the same as used before. For this study, and this figure illustrates that 48 hours post closed head injury, rats administered with pyruvate experienced greater neurological recovery compared to saline-treated rats, with a p-value of less than 0.05. Please remember, or please note, that a p-value is a measure of statistical significance. This figure illustrates that 24 hours and 48 hours post-closed head injury, rats treated with oxaloacetate experienced greater neurological recovery when compared to saline-treated rats, with p-values of less than 0.05 for 24 hours and p-values of less than 0.001 for 48 hours. Also note that despite the treatment administered, all rats experienced greater neurological recovery when compared to the 1-hour NSS assessment for both treatments. So once Zlotnick et al. Knew that pyruvate and oxaloacetate administered post-closed head injury correlated with greater neurological recovery, they wanted to measure the rate, or they wanted to study the rate at which this recovery occurs. So for this study, the rats were given the closed head injury, and this time they were either administered saline or pyruvate for this study, or oxaloacetate. And then over the next X amount of days, various neurological severity score assessments were performed. This study shows neurological recovery over a 28-day period for pyruvate-treated rats after closed head injury. Rats treated with pyruvate experienced greater neurological recovery compared to the saline-treated rats, with p-values of less than 0.0035 for day 2, and p-value less than 0.002 at day 28. This figure illustrates that oxaloacetate-treated rats experienced faster recovery than the saline-treated rats over a 25-day period. At day 25, oxaloacetate-treated rats experienced greater neurological improvement with a p-value equal to 0.0036. Please note that, however, with the drugs administered, all rats still remain slightly neurologically impaired, meaning that their NSS assessment was still greater than 0, which 0 is maximum neurological functioning. As you can see here, they still haven't reached to 0 yet, and the same for the previous study. So they're still slightly neurologically handicapped in a way. The pharmacological effects of greater recovery and faster recovery post-closed head injury were acquired with 1 millimole of treatment per 100 grams of rat mass. So in this study, Zlotnick et al. Wanted to determine the effective concentration at which a 50% neurological improvement was observed. To do this, they induced the closed head injury, but this while decreasing the amounts of pyruvate and oxaloacetate. They started with 1 millimole of treatment per 100 grams rat mass, all the way down to 0.01 millimole per 100 grams rat mass. This figure illustrates the effective concentration in which a 50% neurological improvement was observed for pyruvate-treated rats post-closed head injury. Their EC50 here was 0.05 millimoles per 100 grams of rat mass. This figure illustrates that the EC50 for pyruvate-treated rats was 0.01 millimole per 100 gram rat mass. Note, though, that for both studies, 100% neurological recovery is never achieved. Once they, Zlotnick et al. Wanted to investigate whether these low therapeutic doses could be enhanced by increasing the blood-resident transaminases, glutamate oxaloacetate transaminase and glutamate pyruvate transaminase. The methodologies for both of these studies differ because one was from one year and one was from the next. So for the pyruvate study, the rats were given the closed head injury again. This time, they were given either saline, the low therapeutic dose of pyruvate, which was the 0.05 millimole per 100 gram rat mass. They were given GPT by itself, which is glutamate pyruvate transaminase, or they were given a combination of the two. Then after 2 weeks, the percent neurological assessment was performed. This illustrates that 2 weeks after closed head injury, rats treated with pyruvate plus GPT experienced greater neurological recovery when compared to the saline-treated rats, with a p-value of less than 0.05. For the oxaloacetate study, the methodology was different. This time, they induced the head injury again, and then administered varying low doses of oxaloacetate with GOT, which is glutamate oxaloacetate transaminase. And they did this over a 24-hour period. This figure illustrates that treatment of oxaloacetate with GOT corresponds with greater neurological recovery. Yet again, for both studies, as stated before, administering oxaloacetate plus GOT or pyruvate plus GPT does not correlate with 100% neurological recovery. For the last experiment, Zlotnick et al. Wanted to confirm the blood glutamate scavenging properties of pyruvate oxaloacetate to actually decrease blood glutamate concentrations, and that this decrease in blood glutamate concentration correlates with neurological improvement or a decrease in the NSS. This figure illustrates first off, to do this study, the rats were given their closed head injuries again. This time they were either given pyruvate oxaloacetate, and then over a time frame, various neurological assessments were performed. Each time they did a neurological assessment, they also checked the blood glutamate levels. This figure illustrates significant correlation between a decrease in blood glutamate levels versus neurological improvement, with an R-squared value of 0.19 and a p-value of equal to 0.023. This figure illustrates an even greater correlation between a decrease in blood glutamate levels and a decrease in neurological severity score, or an increase in the improvement, with an R-squared value of 0.89 and a p-value equal to 0.001. Discussion. Traumatic brain injuries are characterized by an elevated concentration of glutamate in the brain extracellular fluids, or like we mentioned earlier, synaptic cleft for our purposes. This leads to excitotoxicity, which leads to poor neurological outcome. However, there can be neuroprotective effects of pyruvate and oxaloacetate when the previous methods of removal are exhausted. The neuroprotective effects we have seen are greater and faster neurological recovery. At low doses, there is enhancement, and this enhancement is, there is neuroprotective properties which are further enhanced by adding the blood-resident transaminases, GPT or GOT. Conclusion. Does the use of blood glutamate scavengers, pyruvate, oxaloacetate administered after an acute brain injury correlate with improved neurological outcome based upon the neurological severity score? Yes. So what does this mean for us? Why do we care? So for someone like me, for instance, this could have meant excitotoxicity prevention post-traumatic brain injury. And if we can prevent it or lessen excitotoxicity, this could also correlate with less long-lasting neurological deficits post-traumatic brain injury. Here are my references. Questions? Dr. Fitz.
Funny you should ask. I have several. You mentioned on a couple of occasions that following post-testing, the rats never got back to 0. Did they do any pre-testing, either in this studies or some of the other studies that you looked at, to see if it was possible that rats in that testing scheme could actually reach 0?
To go back to 100% neurological recovery? They never mentioned it, and I haven't seen any experiments that would suggest that after a traumatic brain injury that you can go back to 100% neurological recovery because of excitotoxicity and the killing of neurons.
But did they, in order to say that you can't return to 100%, you have to know what the baseline is anyway.
Correct.
So if I can't walk a tightrope before traumatic brain injury,
they
probably can't walk one afterwards. So had they done pre-test so that they were comparing the animals to each other, or the animal to itself before
Yes.
and after? So that's how they knew.
Yes, I'm sorry, that's, yes.
Okay.
They wouldn't, per se, have a rat walk a tightrope one because no one could do that, but their ability to, I mean, they were based on simple things that a rat should be able to do, to exit a circle, to walk in a straight line when there wasn't food or something distracting them. So yes, there was a baseline.
The other question that I have relates to the production of alpha-ketoglutarate.
Yes.
So in your scheme, with the increased regulation, with the increased provision of substrate, you would expect then to see an increase in alanine and alpha-ketoglutarate, or aspartate and alpha-ketoglutarate. Are there any downsides to producing extra products in this case?
From the experiments and the studies that I have read, no. Alanine and aspartate are naturally non-essential amino acids. We already have them in us. For the studies of alpha-ketoglutarate, there was nothing that said too much of it was a bad thing, because alpha-ketoglutarate is actually used in, I believe it's in the nitrogen cycle. I also looked up if there was a problem with taking glutamate out, if that had any alterations, and from what I have read, not in this context. That's not exactly what we are looking at this point. We are just trying to lessen excitotoxicity, but they haven't exactly been studying what could this do elsewhere. Would this affect mitochondrial respiration elsewhere in the body and have negative side effects? I looked, I tried.
Thank you.
So, I'm going to piggyback on Dr. Fitz's first question, that they failed to actually get 100% recovery. And my critique is really on the methodology. No one scalped your brain, scalped your head, and then put an iron rod into your brain like they're doing to the rats, right?
Correct.
That didn't happen to you. So
No,
for me, the problem is that the simulation is not exactly a blunt force trauma, like how a human, I mean, we have skulls to protect us for one reason. By, scalping them back and then punching it with an iron rod, trying to simulate that, I think it may be a little bit too harsh to a point that maybe that's the reason why they can't get it back to 100%. That's one comment that people want to answer that.
Perhaps that could be why. Perhaps we kind of have a dampening effect. I wasn't hit directly to my scalp. So perhaps maybe that is a reason why it doesn't go back, but I would say that in my experience, there still wasn't 100% neurological recovery for myself. I've had to go back and relearn, and that's one of the things I talked about earlier, plasticity. Our brains can change and they will compensate for losses as that such.
The scavenging experiment with the oxaloacetate and pyruvate Was there a mention about using a cocktail of both to see some kind of competitive behavior?
There actually, there have been studies of using a mixture of the two, but those were further on. These were the base tests, and then they wanted to see, okay, what happens when we put these together. So
What
I
was
don't.
the result of using a cocktail compared to using singular?
The study that we studied, it showed greater neurological improvement, as far as I know. Because oxaloacetate naturally, if we go back over the slides, it is better. It does more, like you can see from the oh, wrong way. Oxaloacetate has a stronger correlation. R squared of 1 means there's 100% correlation that a decrease in glutamate causes a greater neurological recovery. So this here is very close to 100%. And if we go back to pyruvate, it's not as great. And so the study that we looked at, when you put these two together, it was enhanced, but oxaloacetate is still the greater competitor out of the two.
And did I read it right the first time when you showed the bar graph? It seems that if you just use saline, you don't do anything for 48 hours, you're actually better off than to put pyruvate and oxaloacetate inside the system. It's the first set. The first set of bar graphs. Or the 24 hours and 48 hours.
Yeah.
Yeah.
You're saying, no, you...
So your saline at one hour, the damage is around 16?
16, yes.
And then by 48 hours, it just plunges down?
Yes. Essentially.
So is
Eventually...
that like a lousy control, or what's going on over there?
It's just meaning that 1 hour afterwards, the rats are going to be out of it, just like a normal human being would be. But as time progresses, you're going to get somewhat better, but that doesn't mean that you're going to get all the way better or have complete neurological functioning. So as time passes, it does get better, but not as
I
great.
guess I can see oxaloacetate goes down too.
Yes.
So having something is better than nothing, but nothing also after 48 hours, the brain starts to do some kind of compensation
Right.
and brings you back.
And we see if we're adding more glutamate to the system, we are definitely not better off
Right.
at all. Having more excitotoxicity.
So any animal that's living and breathing ought to be awash in pyruvate and oxaloacetate. So why are our natural supplies not helpful in this situation?
I'm actually not exactly sure. My understanding would be that we don't have enough to compensate for such an injury.
And then
Wait. What else would the pyruvate and oxaloacetate that we would have present, what else would that be doing?
They'd be involved in like the Krebs cycle. So they have roles in that area.
So could you then maybe hypothesize a little bit better as to why, to answer her question? So the question is, if we've got a lot of it, why do you need to add more? And what did you just...
Because we have a lot of it, but it already has a job and a role that it is doing in the Krebs cycle. So that would be why we would need more. It's already occupied to overcompensate for the Krebs cycle for the amount needed.
it's not normally available in the synapse, I guess. That's what I'm getting at. How long did they wait before they gave the mice the pyruvate and oxaloacetate?
They would always, first they would do the 1 hour assessment in every test, and then they would wait 15 minutes after
that.
So they're getting hit in the head, and then an hour and 15 minutes later, they're given the drug. And they're given the drug for a duration of 30 minutes.
And it was like intravenous?
Yes, through their tail veins.
Yeah. Thinking about how it would, you're going to help people this way, you have to get them intravenous very quick.
I wish I would have read more on this study. There was one saying that the reason there was kind of a lapse in animal trials versus clinical trials, and they haven't found a dose of oxaloacetate that isn't toxic to us. I didn't read more
Hang on
into
just
it,
a
but I
second.
wish I would
I'm
have.
sorry. She's still answering a question. So I know that you all are probably done, but we're not. So over there on that side of the room, enough until she gets done. I'm sorry, Callie. Please go ahead.
It's fine. But I wish I would have read more into that to find out what doses I don't know what other organisms they were trying to do the same study